Today we're going to talk about health promotion practice, what that means, why it's indicated, and what the implications might be. Ill health has come to mean many things, but you have to distinguish between health and illness. The World Health Organization has defined health as a complete state of physical, social, and emotional well-being. In addition, the Ottawa Charter has talked about health being the greatest resource that we have in life. Think about it, the greatest resource that we have in our lives. Health will give us not only years to our life, but will add life to those years. Since World War II, we have had an abundance of wealth in the high-income countries, or has led to many countries being high income. After the war, we started to eat far more fat, far more sugar, far more meat, and far more salt than our bodies were really designed to eat. As a result, we now have unprecedented rates of heart disease, hypertension and stroke, type 2 diabetes, obesity, and cancers. These are now the leading cause of death in the high-income countries. I travel around the world a great deal and have had the privilege of going to many low and middle-income countries. And what I'm observing, and has been well documented by the World Health Organization and by many other national bodies, is that with economic development and growth, we are now seeing these patterns of increased abundance and movement away from traditional diets and inactivity, and in some countries, increasing rates of smoking, even though smoking is decreasing in high-income countries. So we're beginning to see another wave of these lifestyle-related conditions, and I do want to be very clear that these are lifestyle-related. People can have tremendously healthy lifestyles and still succumb to heart disease or cancer. So by no means is it necessarily causative. But the evidence is abundantly clear that there are very strong causative links to our lifestyles and these conditions. Well, the challenge becomes one of how do we actually promote health? And not only promote health, but how do we do it within the context of a healthcare system? We have governments that tell us we shouldn't smoke and that we should eat better and exercise more. However, that's not the end of the picture. We need to have these concepts introduced into our daily lives in a way that it's promoted by healthcare professionals. We have had a healthcare system where we have physicians and surgeons who are highly trained to administer medications and to prescribe them in an evidence-based way. We're talking a lot these days about evidence-based practice, and that is that there is scientific research to support the prescription of those medications or the administration of a surgery. However, we also have to realize the power of healthy living and that the importance of prescribing physical activity, of prescribing good nutrition for everyone. So you can have a chronic disease or multiple, as we now know that you can have many superimposed chronic lifestyle-related conditions because they're often all related by an underlying cause, which may be, or contributing factors are lifestyles, and that you can still enjoy a very high measure of health. So we do have to think about these challenges and that we have to make some radically big changes. That just doing a few changes here and there in our healthcare system is inadequate. We have to reconfigure, reconstruct how we actually assess patients, their health and their illness, and how we put these two together in terms of implications for their long-term care. Well, we have to think about how we're educated as healthcare providers. We have to think about how we have come from what we call the biomedical model, which was particularly useful during the era of infectious disease, where you had an infectious microorganism and we had a medication to address it. That model is failing to address the problems and the priorities that we have today. And that's for a number of reasons. One is that these are complex conditions, they have multiple side effects. The medications that people take for these conditions also have side effects. So by getting the focus on the health of the person, there's a great deal of literature to support that you may not need to take medication at all. Or if you do, the potency or the strength of that medication could be reduced, as well as the amount of time or the number of dosages that you take. So as we get the health piece right, we need to work closely with physicians to ensure that if medication changes are needed, if we need to remove them, that can be done, or if they need to be reduced. So it's a very close link between the health promotion side and the invasive care side, the drug side. With respect to surgery, we know that people, by getting the diet, perhaps losing weight, being more fit, that in fact some surgeries are no longer indicated at all, or perhaps less invasive surgery would be needed. So with this kind of model, we are alleviating the load on doctors and surgeries and the need for drugs considerably, and that we will be putting our physicians and surgeons to better use. There's a term now that we call interprofessional care and interprofessional practice. And it really comes from the need for us to, as healthcare providers, to no longer work individually and alongside each other. We really have to work together. We have to assess patients together or share our assessments. We have to decide to what degree do we use the non-invasive approaches related to healthy living, that is, not smoking, good nutrition, and adequate physical exercise. How can we do this, and as that is taking place, to start determining whether drugs are needed or not, or if they are, to help reduce the need for those medications or potentially surgery over the long run. It's going to take a change of attitude. It's going to change the way in which we educate our healthcare providers very early on. So we need to have, right from the beginning, socialized to think of working together. I would also like to say that patients need to see this reflected. They need to see that healthcare providers not just give a pill and say, well, eat a little better and exercise more and come back in 3 weeks. No, that's not sufficient. The public needs to see that that health message is first and foremost on the minds of physicians and surgeons, as well as physical therapists, occupational therapists, nutritionists. Has to be foremost. We all have to be speaking the same language. And from that, share our assessments. And we don't all have to necessarily initiate, but we do need to support. If we do not initiate health behavior change, we have to support the efforts of others and follow up and to see if it has been done. I would say there's much to be done with more medical advances, be it drug research and technology. But we do need to consider that by promoting the health of the person, nothing is better than one's own health. Nothing really is better than one's own capacity to heal oneself. So what we do from a medical point of view or surgical is to enable the individual to support the person's healing. But we do have to recognize that much of that healing comes from that person. So we have to ensure that that backdrop and our nutrition is not only our energy, it's our immunity, it's our recovery, it's our repair. So our nutrition is everything in terms of being our medicine as well as our physical activity. I would say that we can, but it will come. We do need to make a conscious decision about our commitment to health. We can continue to go down this path. When I first graduated, which I like to tell people wasn't a million years ago, people were having their heart attacks when they were in their 70s and maybe their strokes in their 80s. Now it's not unusual to see a young man or woman having heart complaints in their 40s, strokes in their 40s. This no longer is a rarity. We need to become extremely vigilant about preventing these very, very preventable, in most cases, terrible consequences of our lifestyles. Because the tragedy is that you typically do not just drop dead from these drastic events. That with medicine and surgery, we can keep you alive, perhaps for decades longer, in many cases reaching a full life expectancy. But is that the kind of life that we really want our citizens to lead? One with considerable disability, and then to provide the money and the resources into having them being able to have ramps and to have lifts and other adaptations to their home and their workplace. As I mentioned earlier, that when you have that prevention is not only for those people who are out walking around and enjoying a quality of life. Yes, we do need, that's primary prevention, but we have to consider those individuals who do have chronic conditions, be they related to lifestyle-related conditions or not. A person with Parkinson's disease, a person with stroke, a person with a spinal cord injury, they can still enjoy a huge measure of health. The patients that I see have neurological complaints and have because they're elderly, will tend to have many risk factors for lifestyle-related conditions. And what we administer first is a battery of tests about their health and questionnaires about their health. Because until we understand what their health is, we do not know and cannot be sure what the full impact of their presenting disabilities and complaints are. So we really, in our own eyes and in the patient's eyes, put health first. I come back to the message of education. Now, this is education across the board, education of the public regarding expecting health care from their healthcare providers. Not just illness care, but to expect the advice regarding good health. Our healthcare providers, educating them in their entry-level professional education, providing continuing education and professional development to those health providers who are already practicing. To educate the ministries of health in our countries. To educate policy makers who often are not always as well informed as they need to be. For example, myself as a physical therapist, I pride myself in being non-pharmacologic, to exploit non-invasive approaches. Not to the exclusion. Many of my patients certainly need medications and maybe on requiring surgery, but to ensure that it is at the least amount. So I would never recommend anybody just come off medications for the sake of not taking a medication, but to ensure that they're absolutely needed and that they are working and that they're being followed in terms of their health and the adequacy and the effect of those medications. So I believe by working together, and we as societies need to make decisions about choice. Lifestyle is largely about choice. So health has really turned from being a very physical concern to being a social phenomenon because we have choice. And in democratic countries, we value our choices enormously. But we have to recognize that with those choices, fat may taste good, sugar may taste good, salty foods may taste good. But those substances today, if they went on the market and went to the governments for approval, and we looked at their negative consequences, it would be hard to have them approved today, just like tobacco. If we asked the government to approve the substance that's associated with all these negative effects, it would not be approved today. The trans fats, saturated fats, refined sugar, and salt I dare say they would be very, very heavily scrutinized if we were asked to approve those substances today. So we do have some decisions to make, and I, as a healthcare provider, looking forward in my career further to work with other healthcare providers and the public to ensure that we get this health piece right. Health is wealth. Thank you.